Hello, I'm Dr. Scott Watier.
And I'm Tommy Welling, and you're listening to the Fasting for Life podcast.
This podcast is about using fasting as a tool to regain your health, achieve ultimate wellness, and live the life you truly deserve.
Each episode is a short conversation on a single topic with immediate actionable steps. We cover everything from fat loss and health and wellness to the science of lifestyle design.
We started Fasting for Life because of how fasting has transformed our lives, and we hope to share the tools that we have learned along the way. Hey everyone, welcome to the Fasting for Life podcast. My name is Dr. Scott Watier, and I'm here, as always, with my good friend and colleague, Tommy Welling. Good afternoon to you, sir.
Hey, Scott, how are you?
Doing fantastic, my friend. Today we're going to be talking about one of our foundational key concepts of the Fasting for Life podcast and the Fasting for Life lifestyle. We are going to be talking about insulin, normal levels, why we don't test it more than we should, and what we can do to get some clear insights in where you are on your health, metabolic, and weight loss journey. So if you are new to the podcast, welcome in. Excited to have you with us. Thanks for finding us. Thanks for giving us a shot. Excited to be on a fasting lifestyle journey with you. If you want to know more about our journey and the transformation that we've experienced with fasting, head back to episode 0 and episode 1. In about 30 minutes, you'll understand why we do what we do each and every week with the podcast, the resources, the website, the coaching, the challenges, because we truly want to enlighten you that fasting can be an absolute superpower when it comes to your weight and health goals. So, if you're a long-term listener, thanks for listening in. Thanks for all the messages and the emails and the comments and the likes and the rates and reviews. We are so grateful that you are on this journey with us to really combat the obesity and lifestyle health epidemics that we have, not just here in the States, but worldwide.
Yeah.
Absolutely blessed to be broadcast all over the world. Never would I have imagined, 5 years ago when we started this, Tommy, that our story would have been heard and that we'd be approaching 5 million downloads, and just the impact and the experience that we've had. And your messages and your comments and all the stuff you send us, like that keeps us going. So we are so grateful as we come out of Thanksgiving and move into the holiday season. Just want to echo this sense of gratitude for what it is that we get to do.
Yeah, thank you.
And the impact that we get to hear from you guys that we're making in your lives as well. So thank you so much. It truly keeps us going. So Tommy, let's talk about insulin. This article came across our desk. It was from Levels, one of the CGM metabolic companies that are out there. Mm-hmm. And this article was reviewed by Dr. Ben Bickman. So one of the leading insulin researchers in the world. He has such a knack for just being able to break down the complex into simple. I strive to be more like him in my communication technique and style.
Me too.
And he wrote the book, Why We Get Sick. And it's just an incredible, easy read. So I highly recommend it. And it just really talks about this chronic lifestyle state that we live in. And I want to talk specifically about insulin and what insulin is. And a lot of the times, and Tommy, you said this, a lot of the times in our conversations and coaching and challenges, we hear that, well, we know insulin's bad, right?
Right.
However, insulin is absolutely required for normal, healthy function in our body.
Yeah. Not bad. We just want it. We want it within certain goalposts for optimal physiological function and to avoid some of the negative cascades that come about with chronic overly high levels of insulin, where insulin resistance becomes part of the equation, and thus our body's getting a reduced response to any given amount of insulin, and so then we're having to see circulating levels be higher than they should be. So that's suboptimal.
So let's talk about insulin big picture and why it's so important and why it's an upstream lead measure. It's something that we should be looking at more rather than the standard medical tests that are out there. We'll talk about why we think those are not, or give you some reasons, clinical reasons and interpretations as to why we don't think it's ordered or used in a routine kind of health profile, yearly blood work type application. But insulin in itself has a sensitive relationship with every organ in your body.
Right.
So in the bad side of insulin, which is this insulin dysfunction or insulin resistance, which leads to several chronic conditions. And sadly, it's connected to 8 out of the top 10 causes of all-cause mortality. So insulin resistance and hyperinsulinemia, elevated insulin. Now, you're thinking, well, my fasting blood glucose is normal. Yes. But in my case specifically, I had a fasting insulin of 22. So I was one of those undiagnosed pre-diabetics because I was walking around with normal blood sugar, slightly elevated liver enzymes, slightly elevated blood pressure, central adiposity. I was an old power lifter. So I carried the belly, right? To be able to move the heavy weight, you had to have the weight, look like a strong man in the off season.
Yep.
So I had a lot of those signs: chronic fatigue, sleep disturbances, high stress at that period of time, being a clinic owner and in private practice. So the reality is that when we look at how insulin is connected and why we care so much about it is because insulin dysfunction, right? And then we'll talk about all the good things insulin does in just a second. Then we'll talk about normal levels, how to get tested, and then ultimately why it should be a key metabolic indicator in what we look at in terms of health metrics and how we look at this. Not just weight loss, but long-term health metrics. So 8 out of the top 10 major causes of all-cause mortality, we've got cardiovascular disease. So elevated insulin and insulin resistance are strongly associated with increased risk of atherosclerosis, coronary artery disease, stroke, and overall cardiovascular mortality. And that's, again, related directly to diabetes, metabolic syndrome, cardiometabolic risk. Cancers, hyperinsulinemia promotes cancer cell growth and cancer cell survival. So cohort studies have shown that high fasting or 2-hour insulin increased fatal cancer risk, particularly liver, colorectal, pancreatic, and breast cancers. Stroke drives vascular inflammation, increases clot risks. Alzheimer's and dementia, type 3 diabetes, right? Directly related to metabolic breakdown of that insulin signaling. Chronic kidney disease, chronic liver disease, so non-alcoholic fatty liver disease. We're seeing those numbers skyrocket here in the United States. And respiratory disorders and infections, which is a resistance or an impairment. Insulin resistance impairs proper immune function, making those chronic infections or respiratory disorders lethal.
Yeah.
So insulin's harmful stuff goes beyond just looking at it from, oh, it's a diabetic marker, or, oh, I need insulin to manage my blood glucose. It touches nearly every major pathway contributing to all-cause mortality in Western populations. So insulin optimization, insulin understanding is a critical marker for prevention-focused health, longevity, weight loss efforts. Like, it should really be a keystone of something that we talk about and have a good understanding of, so then we can make better choices and ultimately get the results that we want.
Yeah, if we think about insulin as more of like a traffic controller of energy, of fuel storage, fuel mobilization, where is the fuel and where is it going? If we think about insulin as the main control point for that biochemically in the body, then things start to make more sense, because even when you just mentioned like the immune system, so fighting infections and fighting underlying problems that could lead to bigger problems. So we have an underlying immune system function, but when insulin is too high, when we're in a state of insulin resistance and we have an overabundance of insulin, then we're robbing the fuel from the immune system, for example, in order to promote growth or storage of fuel somewhere else in the body. So then you have a deprioritization of important bodily functions with an upward raising of the prioritization of certain fuel mobilization, but also fuel storage. So we can be taking in the correct number of calories. We can be taking in good food, good nutrition, and then we can still be overly storing more of those calories as fat while we rob the muscles and rob the immune system of fuel that it needs at a given time. So that traffic control point is imbalanced at that point. So that's just one of the many issues that insulin resistance and too much insulin at any given point can cause within the body.
So let's talk just rat-a-tat-tat. What is insulin and what is it? How does it connect to those other organ systems in a positive way? Because we need it. So it's a chemical messenger, circulates and triggers physiological events. It's produced in your pancreas by your beta cells. and it affects every single cell in your body, including your bones, your brain, your muscle, your skin. So brain, it's going to be neuron growth and neuron health, glucose used for energy. We see this with now the emerging research on the unreliability of the plaque model for Alzheimer's and dementia, degenerative brain disorders. So it's going to tell your brain to be able to use glucose for energy. It actually is connected to your ears for proper hearing. It's connected to your heart for proper energy use and healthy heart size, and it helps lower blood pressure when at a healthy level. Salt gets blamed for what insulin causes. We talk a lot about salt on this podcast, so as you know. It's directly linked to muscle for energy use and in muscle protein production and muscle growth.
Right, it's anabolic.
So insulin is anabolic. It helps grow your muscle. So we do need some insulin. It also converts excess glucose to fat storage, and fat cell growth. Boo, thumbs down.
Right.
Liver, glucose storage and fat production. It goes right to the gonads, so the testes and ovaries. It's paramount in normal sex hormone production.
Correct.
It's paramount in bone growth and bone energy use. So as we age, we have this osteopenia, osteoporosis epidemics, specifically in postmenopausal women. Well, if insulin's not in check, you're not going to have proper bone formation or bone strength or bone health. And it helps the nerves use glucose for energy and neuroplasticity. So insulin is not just pigeonholed into or painted into the corner of something that we only need to look at when it comes to blood sugar and diabetes, right?
Right. And it also shouldn't be pigeonholed that it's a bad thing, or that it always needs to just be low or minuscule or diminished in all cases, because that's certainly not the case. But for one example, if you're talking about for bone growth, let's say, for example, so it's not necessarily the level of insulin that most people have an issue with. Now, of course, clinically that does exist. But when we talk about insulin resistance, then the trouble would be that the bones aren't able to actually pull the proper fuel into the cells in order to promote that bone growth. And that's because of insulin resistance. So it's like the insulin's present, it's there, and it's there in sufficient, maybe even overly sufficient quantities, but then it's not having the effect on the glucose transporter. For example, that's a big one that works all throughout the body. There's many different glucose transporter cells or receptors rather. So that's problematic. And so you have a similar thing where insulin can be in sufficient quantities, fuel can be in sufficient quantities, but if you can't get the fuel into the cells, then you don't have the tissue growth that you need right there.
So insulin is a health metric, right? So if you don't have diabetes, why should we be looking at this? Right? Like, why does this matter? Well, we know that in the diabetes category, 37 million Americans and another undiagnosed or pre-diabetics, about another 80 million Americans. So anywhere from 40 up to 120 to 130 million Americans dealing with an insulin issue. And this term insulin resistance simply means your cells have stopped responding to appropriate insulin levels.
Right.
And there's a lot of mechanisms. So a genetic predisposition, overconsumption, excess fructose, excess visceral fat, obesogenic food choices, high glycemic, high carb, high fat foods, the food environment that we live in today. If you're looking for a great book on that, Salt, Sugar, Fat by Michael Moss. An incredible eye-opening experience onto our food supply. But this numbing effect takes place, and then your body is in a constant state of trying to achieve homeostasis or balance. So the mechanisms driving insulin resistance go all the way down to each individual target tissue or cellular level. So as your tissues become less sensitive to insulin, your body creates more insulin to meet the physiological goals. So then the elevated insulin worsens the resistance, and then you end up in the category of type 2 diabetes. But before that, there's this long-term kind of beneath the surface metabolic dysfunction that's taking place. We're not talking about metabolism and calorie burning here, but we're talking about health of the cell, ultimately then upstream health of the body overall. So if we're carrying the excess weight, which 75% of the population is, then we're fueling the fire to develop this, putting insulin in the prime driver of chronic lifestyle conditions, 8 out of the top 10 reasons of all-cause mortality. And never mind the, inflammatory response from that excess weight, the metabolic activity of that visceral fat, et cetera, et cetera. I can just keep listing them off, but I don't want to do that.
I think even at the core of, you started this conversation asking a question: why don't we hear more or test more or see more about this? Like, why do we not hear, hey, you need a fasting insulin test?
Why is my doctor not putting this into my yearly blood work?
Correct, right? And so I think one thing to understand is that you don't have to have excess weight in order to have an insulin issue or have layers of insulin resistance.
Right.
But also, if you do have excess weight, it doesn't necessarily mean you have a bad insulin problem or insulin resistance. You could have one without the other, excess weight or insulin resistance. But there is a lot of overlap there. And even just understanding the fact that insulin gets conflated with insulin's only an issue if diabetes is an issue, but that's really not the case. It's just that the diagnostic standards for who has type 2 diabetes have always been with regard to what is your need for exogenous insulin? Do you have such a high level of insulin resistance that your pancreas can no longer keep up with the demand to lower your blood sugar, and thus you need to actually, I say need in quotes, to inject more insulin in order to get that blood sugar to come down. But as you can see, that's really just perpetuating the same problem that slowly built up and got you to that point. So it's really not backing you off of that situation at all. So why don't we hear more about it? That one, I think misunderstanding what the correct order of such a long-term set of problems, right? Because insulin resistance is slow, it builds over time, and it's not always easily detected because your body has a big level of flexibility and margin. You have a lot of margin within the blood sugar control set points where even if you need double or triple or quadruple the insulin from your pancreas that you did 10 years ago or 30 years ago, your body can still respond up to a certain point and keep the blood sugar within the normal range, quote unquote. So that means HbA1c looks good, fasting blood sugar looks good, even if you're wearing a CGM, might look okay because your pancreas is able to keep up. So your curves look good, your response looks good, but at the same time, underlying, you're seeing your level of insulin actually go up, and I mean it could be going up. You mentioned your number before, 22, right? Making you an undiagnosed pre-diabetic. Well, if we look at our levels now and it's 2, it's 3, it's 4, it's in this low single-digit range, which is fantastic. That means you could have had a 10x level of insulin, of fasting insulin, when you were an undiagnosed pre-diabetic. So that's a huge range for a margin of error right there to go undetected for a long time.
So let's talk about and what you were just talking about there was why don't we know what an optimal level of insulin are, and why is this not a test that's readily available? I'll give you 3 reasons in just a second, but what you were just mentioning there is insulin was historically viewed as a downstream effect of serious illness rather than a cause.
Yeah, there you go.
But the tide's been turning lately. So research has been published, papers arguing for insulin's pivotal role in aging, cardiovascular disease, type 2 diabetes, obesity, inflammation, cancer. But the former prevailing wisdom was that elevated insulin doesn't cause disease. So if we don't know what the ideal level is, and it's not really going to change our clinical outcome, why should we be looking at it? So the 3 reasons, in my opinion, of why it's not a readily used test are the following. Typically, it's used in this case if you have hypoglycemia. So are you potentially a type 1 diabetic? Or you might have an insulinoma, a pancreatic tumor, because it's going to drop blood sugar to dangerously low levels.
Yeah.
So you need to look at fasting insulin and C-peptide and glucose to see, okay, do I have a tumor? Do I have a Am I a type 1 diabetic? Do I need to save my life in this situation? Occasionally, it's used in endocrinology or research settings to help assess insulin resistance, but that's only in atypical cases of diabetes. So after you've already gotten the disease.
Right.
Or severe metabolic syndrome that's not responding to standard medical treatments or clinical interpretation or clinical application. And it's not a standard in screening of diagnosis of type 2 diabetes or prediabetes or metabolic syndrome. The standard screening right now focuses on the downstream, the fasting glucose, the A1C, or maybe an oral glucose tolerance test. So most of the guidelines or clinical protocols don't recommend fasting insulin, largely due to a lack of consensus, standardized reference ranges, and the fact that it was seen as a downstream, not an upstream hormone in the disease process.
Yeah. Yeah, it was the order of operations was flipped because it's such a long-term thing. But now that we know better, we can do better. Because if you took a type 2 diabetic and said, hey, you know what? What if we had figured out that you were on this path and it was serious 10 years earlier? What about 20 or 30 years earlier? Because if you were looking at fasting insulin, you have a very high likelihood that you would have seen that. You would have seen something going on. You would have seen, if you were tracking fasting insulin, you would have seen it tracking up before those fasting blood sugar numbers started to get out of whack. As the symptoms kind of started to accrue, and it was just like, well, let's keep an eye on it, and we'll see what happens. You could have intervened much earlier in the process.
Yep. So the lab range is typically from 5 to 25. It varies a little bit differently on what lab you use. But that can be a 5x difference just in that normal range.
Yep.
So there was a bunch of studies that were done. Dr. Mark Hyman, Dom D'Agostino, Dr. Perlmutter, Ben Bickman, Rob Lustig. The consensus really is less than 10. Some are a little bit more stringent, less than 7, less than 5. Right? But anywhere in that, if we just kind of average them out and get the mean and the median, we're going to be looking at anywhere from like 4 to 7 is a healthy range. We do know that there's a study that clearly indicates that if it's 7 or above, you are more likely to develop a lot of those lifestyle chronic disease processes that we mentioned earlier. But the problem is why we don't have like a clear-cut optimal level is because we talked about this disconnection of it. It was viewed as a downstream effect, not an upstream metric. And that insulin is entangled with so many other independent factors like body mass index, body weight, insulin sensitivity, insulin clearance, diet, exercise, ethnicity, stress, sleep. It's multifactorial. So when we're looking at the motivating factor as to why or how we get our insulin tested, this could be, for me, in terms of my health journey and what I want to accomplish in terms of changing the path of my generational health for my family, is I want to know what are those upstream metrics that I should be looking at. And that's why we have the optimal lab range PDF, the resource that we have. So what are those markers and why we should be looking at them as a preventative rather than a reactive approach to our health? So you can get a fasting insulin test. Typically, it's a basic blood draw. It can cost as little as $20. You can go to your provider and ask and be your own self-advocate for your health care. But a lot of the times, the docs aren't going to order it. I had a client back in the day. He got diagnosed with prediabetes, started fasting. I was coaching him. And he went in. He got his initial blood work done. He did not have a fasting insulin number, right? They just didn't order it like we talked about. And then at the retest at 90 days, I was like, hey, ask for fasting insulin, HSCRP, vitamin D, just get a fasting insulin. So he ordered it. The doc kind of was like, yeah, okay, we'll order it. Went to the nurse, handed off to the office staff. Okay, yep, we'll order it. Goes and does the lab draw. Guess what? Didn't order the fasting insulin.
Okay.
He was like, but I wanted this. But the doc was like, but why? We already know you have the issue. He's like, but okay. So he just went and got it. He went to any lab test now here in Texas, paid for it, got it ordered, was able to get it to him, get it done. And his His fasting insulin was in the teens, the middle teens.
Mm, that borderline kind of range.
Yeah, I mean, it was in the, I think it was either 15 or 16. I can't exactly remember.
Yeah.
But then he was able to go take his CGM data and calculate his actual HOMA-IR, which is the gold standard. It's the homeostatic model assessment of insulin resistance. So it takes into account, it's an equation, it takes into account your blood sugar and your insulin number, and it calculates a healthy range. So a score of less than 1 is interpreted as healthy. And when he started, he was up in the 2.5 range, but now over time, he's been able to decrease that. And it has not been a perfect journey. He still travels and eats and enjoys his life, but now he knows what he should be checking in on periodically to know if he's creating a downstream problem in the future.
Yeah, that's great. When I had about 70 pounds to lose, I was somewhere around 18, 19, like at my peak for fasting insulin. And then after dropping about 50 of that, so maybe, somewhere around 75% of the way, I didn't test it again, like at any point between, so I don't have all of the data points.
Right.
But I was down under 3. So like there's no test that would show that would give me like an elevation or any sort of like, red flag right there. So it's always in the very, very low range after that. So I didn't have to take all the weight off to see all of the improvement in insulin resistance. And again, just because you have 70 pounds to lose, you may not be at an 18 or a 19, but I was. And
Right.
I didn't know it because my blood sugar would come back fine. My HbA1c would always be in like the, hey, that's not great kind of range.
Yep.
Not great, but nothing to do about it essentially at this point.
Yep.
Watch your carbs.
Watch and wait.
I would hear things like that.
Yeah.
It'd be good to lose a few pounds.
Exercise.
Yeah, I know that. I know.
Right.
I'm trying. So
Right. And the A1C doesn't take into account the time under the curve
yeah.
as well. So where are those variabilities? That's why we love a CGM for a short-term
Mhm.
application to give you some insights into your day-to-day, your food choices, your sleep, your stress, your hydration,
Yes.
et cetera, et cetera. But let's talk about how to lower your fasting insulin.
Okay.
So we'll give you a few things here. Number 1, time-restricted eating, aka intermittent fasting.
Mhm.
What is the quickest way to decrease insulin and to increase insulin sensitivity when you open up your nutrition window to eat? Because it's two-edged sword, right? You want to stimulate insulin sensitivity? Well, time-restricted eating. There's been dozens of studies looking at a 10 a.m. to 6 p.m. window or 8 a.m. to 6 p.m. You definitely have more insulin sensitivity, or insulin. The insulin can handle the food load better earlier in the day. So we've changed our tune on this over the years.
Yeah.
OMAD dinner, not a long-term strategy. We definitely want to shift that eating opportunity or eating window earlier in the day, but time-restricted eating, fasting, it's the quickest thing you can do to decrease that insulin load and help that blood sugar and insulin normalize.
Yeah. Also, take a look at the blueprint to fasting for fat loss. When we talk through some of the fasting schedules that are in there, and also just like a visual representation of your plate. If you think about your plate as an opportunity to prioritize protein, to be looking to hit at least 30%, if not closer to 40% protein as your calories, guess what? The insulin load required for protein is so efficient. So you have an insulin response, but it's a very efficient one. And so typically here with a standard American diet, we're usually looking at somewhere on average about 50 to 60% carbohydrates. But when we're prioritizing protein first and then putting in healthy fats as well, then guess what? Carbohydrates get to go into the back seat. They might be 15, 20% of your nutrition for any given plate. That's going to minimize the insulin load required during that meal whenever you went to break your fast. And then you combine that with fast cycling, where after that meal, I'm getting into my next fast. So I'm not just being kind of sporadic and a dabbling faster, but I start cycling my fast. Then on my next fast, I get to actually, not only did I control my insulin load on the front end when I broke my fast, but then when I went into my next fast, that time is the only way to allow insulin levels to come down. It
Yep.
just takes time. So every additional hour of fasting means my insulin level came down before I broke my fast again and then required an insulin spike again. So that means average insulin gets to just trickle down over time. And that's how we get this major physiological healing over the long term.
So let's talk about food choices and macronutrients. You already alluded to it there in your explanation, was increasing your protein.
Mm-hmm.
That's going to slow down glucose absorption. It's going to increase your satiety signals. It's going to lessen the chance for an insulin spike. Also, low glycemic. So not no carb, low carb or smart carb, right? Cold resistant starch, white potatoes, sweet potatoes, starchy vegetables, fiber. Increasing fiber is going to slow down your blood sugar absorption by your GI tract.
Yeah. I mean, we were talking beforehand about potatoes versus rice and how if I have rice, and my main exception being if I'm going to have some sushi, I'm going to have some rice for sure.
Yeah.
Any other time, I'm usually avoiding it because it just doesn't make me feel very good, and it's dose dependent. It is dose dependent, but I do enjoy eating it, but I don't feel great with it. But whereas with a potato, it doesn't have to be a sweet potato. I'll just feel better. I'll sleep better too.
It's one of the most satiating foods on the planet, and it's been so dramatized as the evil category of carbohydrates. Right now, if you're on insulin and you're a diabetic and you're trying to reverse diabetes, go in low carb or low glycemic load, right? So foods that slow the blood sugar digestion into glucose, and glucose then ultimately into insulin once it gets into the bloodstream. So going low carb, absolutely. Adding exercise in, absolutely. That's going to be one of our next recommendations. So fasting, increase protein, increase fiber, eat more low carb. You're going to see the biggest bang for your buck in getting your insulin in check and getting that scale moving in the right direction. 3 things left. Exercise. Zone 2 training. So we're talking about zone 2. We're about 60 to 70% of your maximum heart rate. This is going to be an intensity you could sustain for about 30 minutes, and where you can still have a conversation, let's say if someone was standing next to you. Okay. If you get into that higher, out of breath, can't breathe, shortness of breath, couldn't hold a conversation, couldn't do it for 30 minutes, you've entered zone 3 or zone 4. Okay. So before we get in, so we don't get into all the nitty gritty, well, what's zone 2? How do I calculate it? Simplest way to do it is 60 to 70% of your maximum heart rate. So this is an intensity you could sustain for an extended period. You notice your heart rate's up, elevated slightly, but you're still able to hold on to a conversation and being able to do that for 30 minutes or more.
Brisk walk, probably.
Yep. That's going to correlate with a lower fasting insulin level. And it's going to also increase the insulin sensitivity or the effectiveness of the insulin in your body at the cellular level.
You mentioned low carb, especially if you're type 2 diabetic. What I also like to think about is just the fact that in order to get your insulin right, you don't necessarily have to plan to be low carb or especially not no carb for the rest of your life. You can always pull that lever, like you can always maintain a level of control over your insulin loads anytime you're going to break your fast. But over time, like as the weight comes off, as you get insulin resistance in check, you'll become more insulin sensitive. You'll be able to handle carbohydrates, differently, better, probably in a larger amount. Like, so if you don't like ketogenic, let's say, ketogenic diet can be very powerful, especially in a 30, 60, 90-day cycle, but long-term, lower adherence. And so thinking about the fact that you don't have to necessarily do that for life to maintain really good benefits and optimal health, optimal blood work, and maintain control over the scale, I think that's a really important thing, because it can be used as a strategic lever now. And you'll probably, if you're paying attention, you'll probably find a good balance point for sustainability on the long term. Like I said, for a while there, I was reduced on the carbohydrates. I never stuck with keto for a very long period of time, but I got more like cognizant about my carbohydrate intake. And so now, knowing I usually stay away from rice except for on sushi occasions, but I'm good with potatoes. It helps me not think about carbohydrates in like a black and white or kind of demonizing a food group kind of way, which leads to much longer success in the long term.
Yep. The second category of exercise is going to be resistance training.
Mm-hmm.
So 2023 systematic review of meta-analysis, 27 studies, obese or overweight. Researchers found resistance training improved insulin sensitivity. So start with 2 full body strength training sessions a week. That's it. Not 7 days a week. Don't do that. 2, then go to 3.
Yeah.
Once you get to 3, you're probably going to beat your sweet spot. So zone 2, resistance training. Last 2, these were huge in my descent down the blood sugar, insulin resistant rabbit hole back in the day on my own health journey. Stress and sleep. Poor sleep quality or deviating from standard sleep patterns, higher glucose levels, and worse blood sugar control the next day. 2022 systematic review, 10 studies found that short sleep duration was significantly associated with insulin resistance, minimum 7 hours a night. Try to reduce sleep disruptions. Go grab our sleep guide. It's a free infograph PDF. You can go to the website, thefastingforlife.com. You can grab it. It's in the show notes. And some consistency around sleep. Sleep is so incredibly important to healthy insulin and metabolic function and blood glucose regulation the next day. Never mind the cravings and the ability to stick to your fasting windows that you've set.
Yep.
And the last one is stress. So several mechanisms link stress to high blood sugar and insulin resistance. So psychological stress can impair your beta cell function, so your body's ability to produce insulin from the pancreas. And it can release excess cortisol, which promotes the accumulation of that visceral fat, the fat around the belly or the abdomen.
Mm-hmm.
And that absolutely is directly connected to a driver of insulin resistance. There was a study that was done in type 2 diabetics where simple 5 to 7 minutes of meditation or deep breathing decreased their postprandial blood sugar, the post-meal blood sugar, by 30%.
Wow.
I don't know about you, but my phone lives on D&D these days.
Yep.
Because of the distractions and just all of
the chronic stressor.
The chronic stressor. I don't turn on the news. Oh, heck no. I don't need that extra stress.
Yeah.
I got 3 jobs, businesses, kids, wife. I'm like, no, I'm good. I don't need that in my life.
Yeah.
So stress, sleep, exercise, fasting, fiber, protein, and low carb, not no carb forever. Final thoughts, Tommy?
Yeah. I want to give a shout out to a 36-hour fast, because a 36-hour fast is, we hear a lot. What's the best fasting schedule? What's the perfect fast? Like, there is no perfect fast.
Give me
There's
the
no
plan.
perfect fasting schedule. But if I had to give a shout out for insulin resistance, 36 hours is just huge. So if you need a target for your next fast, or you want something that you're kind of working up to in order to get at, old levels of insulin resistance, start working those backwards, start working on that as a major goal of yours, a physiological health optimization goal of yours, then shoot for that. Because, going from breakfast one day to dinner the next day is maybe not accessible, right from the very beginning. You might want to take a little bit of time to kind of work your way up to it. And that's okay. Like, having a goal to be able to do more 36-hour fasts on occasion is huge for insulin resistance. So start off with 16, 18 now. Do those. Take a little bit of control over the carbohydrate and over the meal timing. And it's going to make your next 16, 18 hour maybe a little bit easier to extend it into a 20 or a 24. And then from there, you're just a hop, skip, and a jump away from your next 36 and really getting at those levels of insulin resistance and getting some more insulin sensitivity in your physiology.
And if you're wanting some holiday help, right, because we're coming out of Thanksgiving, moving into Christmas and New Year's.
Oh, yeah.
Next week's episode, we talk a lot about how to take the pressure off of the holidays and really, focus on what matters, not that this should be an aggressive fat loss month for anyone. Mm-hmm. Maybe a few of us out there. But for the majority of folks, listen into next week's episode. But as we wrap up today, insulin truly might be the most overlooked driver behind some of the greatest health challenges that we see. We mentioned them all. But learning to recognize, test, and optimize insulin early we can disrupt the root cause of much of the chronic illness and all-cause mortality that we see. So focusing on insulin health isn't just about the numbers on a lab report or the number on the scale. It's about rewriting the story for longevity, vitality, and most importantly, prevention in our healthcare system. So advocate for your test. Go get it yourself. But lowering and balancing insulin from a blood sugar perspective could be the most powerful step you take. Fasting is the best and most easiest way to do it. That's why we adopt the fasting lifestyle. That's we teach it, preach it, live it, love it every single day on every single week in this pod.
Oh, yeah.
So, Tommy, I appreciate the conversation. As always, if you're looking for a resource, head to the show notes, grab a link, grab a sleep resource, grab the blueprint to fasting for fat loss. Reach out to us if you got questions. Appreciate the conversation, man, and we'll talk soon.
Thank you. Bye.
See ya.
So, you've heard today's episode, and you may be wondering, where do I start? Head on over to thefastingforlife.com and sign up for our newsletter, where you'll receive fasting tips and strategies to maximize results and fit fasting into your day-to-day life.
While you're there, download your free Fast Start guide to get started today. Don't forget to subscribe on iTunes, Spotify, or wherever you get your podcasts. Make sure to leave us a 5-star review, and we'll be back next week with another episode of Fasting for Life.